Thank you. This is an interesting area. It's not well researched, but particularly in the orthopaedic surgery area, a number of surgeons are wanting their patients having some form of exercise and prior to their surgery to get them a bit fitter. It makes a lot of sense. So when you actually extrapolate this to polio survivors or other individuals with other conditions such as neurological conditions, it actually makes even more sense, because generally as a result of the neurological condition, you've had a long period of inactivity and you've become quite deconditioned. And really, for surgery to be most successful, the individual needs to be at their best at the time of the surgery. So I just want to wander through a few constructs. I'm certainly seeing a number of my polio survivors having surgery. Now, those of us who are old enough to remember, in the mid-90s, no one had surgery. The surgery that polio survivors had was usually when they were a child, when there was so-called corrective surgery that was undertaken, and that actually ended up with more problems than benefits in the long term. But we're now in a situation where surgical techniques, surgical equipment, anaesthetics, and understanding of the outcomes of the surgery are much greater, and that's only in 2 decades. So most of my patients now who need some form of orthopaedic surgery in particular, I would strongly support, but we need to work them up. Okay, so what's prehabilitation? Well, it's rehabilitation with a P in front, if you want to look at it in a simplistic way, which tends to suggest to you that you're going to look at a multidisciplinary approach, and that's certainly what I would advocate. So, this is the process of enhancing functional capacity. So you want to make someone more capable before their operation so that you can withstand the stress of the surgery, because that's an insult. And if you think of you who've been diagnosed with post-polio syndrome, the time that the diagnosis really started to come to the fore was after you had something significant happen in your life. So surgery is significant, with the ultimate aim of at least maintaining the level of functionality before the surgery, or even improving the rate of recovery after the surgery, so that you don't spend as long in hospital, because the most dangerous places in the world are? Hospital. If you've got someone like me running around a hospital, you should be in trouble. Okay, so if you have post-polio sequelae, this is a challenge when surgery is contemplated. So if you think about it logically, we've already had a number of discussions about people having surgery on their good leg. So that means that the affected leg has to take on an extra load in the post-surgical situation or post-operative situation. And it may not be capable of that. So you really need to target how you're going to manage this process. You also have the issues with pain, fatigue. So an able-bodied person has a hip operation, they lose at least 2 litres of blood. They're shattered for the first couple of days after the surgery. Well, the first couple of days they're not so shattered because they don't move around, but once they start moving around, they really notice what's happened to their body. So if you've already got pre-existing fatigue or weakness, you're putting another layer on it. So you want to make sure that you're addressing these issues early. So it makes sense to try and get the person as good as possible at the time of the surgery to minimise any physical decline. And may add in there psychological and emotional decline as well, because as we've discussed, if you're an achiever and you can't achieve, it has significant impacts upon your psychology. So, where a clinical or surgical intervention is appropriate to lead to improvement in quality of life as well as function, then you've got to be prepared to consider the intervention. So someone says to me, I'm having cardiac surgery, I could die, but I don't want to have the surgery because it might make my polio worse. And I've had that said to me. And the answer to that is, hang on, let's think about this logically. You're talking about a life-threatening situation versus a functional situation. I think you've still got some value on this earth. Let's treat it and make sure we're addressing the most important issue. So, but the critical thing here is that the assessing clinician really needs to look at the whole person. So an orthopaedic surgeon will be looking at the hip. I can fix that, I can make that better. I do my ward round after the surgery. Oh, everything's perfect. You can go home tomorrow. You haven't been up yet, A good clinician will understand the ramifications of anything involved before the surgery and after the surgery. So you have to take into consideration the whole person. So, in your preoperative workup, you need to assess the whole person. You need to understand the general medical status of the person. So, how many of you have issues with blood pressure? How many of you have diabetes? How many of you have had a little bit of cardiac issues? Are there orthopaedic problems? So all of a sudden, you're not just about that surgical situation. 50, 60% of you are saying to me, I've got other things happening in my life. So we need to make sure that you are as in tip-top shape as you can be before you go into surgery from a medical perspective, because if you're medically stable, the risks go down. You need to understand what the functional status is at the time prior to the surgery. Can you improve that functional status before the surgery, and what will be the intended functional status at the end of the surgery? So there need to be appropriate goals of treatment. And then, unlike the usual private hospital orthopaedic surgeon, you're out in day 3 or day 4, there needs to be some follow-up to make sure that all the functional challenges that occurred are addressed before someone goes home. Because if you go home and fall, we're in trouble. And it's also really useful for the assessing person to give some written information, because when you're told you need surgery, sometimes it's a bit overwhelming and you don't take everything in. So written documentation is really important as well. Okay, I'm going to go backwards here. And why I'm going to go backwards is everyone talks about the physiotherapy side of things. But in the polio situation, I believe that the psychology of this is the most important part. You need to feel that you're in control of the situation. None of you like being out of control. All of a sudden you're putting your hands into someone else's control. That's fairly angst-provoking. So when I talk to my patients, I want to know what their previous surgical experiences were. How did they cope with the surgery? How did they cope with the anaesthetic? How were the nursing staff? How were the physios? How were the doctors? How were your family? Because sometimes your family are helpful and sometimes your family are a hindrance. So you need to understand what's happened there before. How do you cope with stress? What do you do when you're put in a situation that's slightly getting out of control? Do you ignore it and go harder, which is what most of you did when you were younger? Or do you actually have the ability to ask and delegate and get someone to give you help? Because that's really important, because you're going to be physically challenged after the surgery. What are your concerns about the anaesthetic? If you read all the literature out there, the Post-Polio journals and that, everyone talks about the risks of anaesthetic. I like Bruno's two times approach, because in fact it does take, you often need a lighter anaesthetic, and it does take longer to wake up, because there is an increased central sensitisation to anaesthetics and centrally acting medications. And also the fear of pain or weakness or fatigue after the operation, that needs to be explained. One of my biggest frustrations is that when my patients have back surgery, the surgeon never actually discusses with them that they actually break their back to get into the area. And you'll have, even last week I had a young patient say to me, it feels like my back's broken. So my response was, it is. And it's going to take, the first 2 to 3 weeks are going to be really sore, and then it's just going to gradually improve. So understanding the technique of what's happening to you makes a lot of sense. Because often patients will talk about after back surgery, my legs feel better, but my back's much worse. Well, it is. And that's what we expect. So expectations of what's going to happen after the surgery. What about the team looking after you? Do they understand the late effects of polio? Do they understand that the ramping up exercise isn't the same as what it used to be? You need to be able to pace yourself, build it up slowly, periods of rest, all those sort of things. Do they understand your functional needs? And also, from my perspective, understanding the role of rehabilitation, because any of my patients who have a joint replacement, for example, I basically write to the surgeon insisting that they refer them on for some rehabilitation afterwards because it's going to take time. And get the concept of enabling that happens with rehabilitation. Although, once again, as I mentioned in my first talk, polio survivors often need to be slowed down rather than quickened up because there's a boom process there. So the sort of things we discussed, which I've sort of gone through already, we talk about the sensitivity to sensory-lacking medications and local anaesthetics. A classic example is simple day procedures often become overnight procedures because of the anaesthetic, not because of the procedure itself. Thinking about blood banking, your own blood before the surgery, particularly with hips and knees where you lose a couple of units of blood. And also discussion with the surgeon about positioning on the table. Because if someone's got fairly significant degenerative back disease and they're put on their side for the hip replacement, that can have ramifications. It's really important to understand that inactivity leads to functional decline. So if you don't use it, you lose it. But that doesn't mean you have to overuse it either. So one of the things that's really important in that prehabilitation state is to actually start doing things again. Targeting your activities that you're going to try and achieve after your hip surgery, for example. So if you were previously a walker with a stick or a frame, but you've had to go into the wheelchair because of your hip pain, but you want to be able to walk again, then some of the physiotherapy should be looked at vertical activities. Doesn't necessarily making you walk heaps, but get your body used to being vertical. Because there are cardiovascular issues if someone's not used to being vertical in terms of blood pressure changes and like. So you want to actually start educating the person about what you're going to achieve and start trying to address that before the surgery. It affects all aspects in activity. So if you don't use a muscle in a week, it loses 25% of its conditioning. So it doesn't take long to become pretty weak. So in this day and age when we have surgery, our patients are often, orthopaedic surgeons are often up and about day 1, day 2 after the surgery. In my old days, it'd take, we'll get them up in a week, we'll get them home in 2. That's not the way it's done now. But there's a cost with that, and the cost is if someone's not prepared for that, the risk of further injury is greater. So you actually have to understand that you've got to gradually build that up. If you can improve your pre-surgery function, there's clearly a decrease in the risk of morbidity, which is further illness or injury, and mortality, which is death. So that's one of the things that's been shown, not in the polio group per se, but in the studies. So we know that we can decrease hospital length of stay. Insurers love that. The governments love that because they don't get bed blocks. But most importantly, where's the nicest place to be? Home. So if you don't have to be in hospital, there's a bonus. From a medical perspective, we need to look at all the comorbidities. Weight is a big issue. I get very frustrated when overweight cardiologists tell my polio patients that they should eat less and exercise more. It happens. It's difficult, and we had one good talk by a dietitian yesterday, and one of the issues, of course, is to lose weight, you need to put up your metabolic rate. One of the concerns with that, though, is that putting your exercise rate up above the age of 50 doesn't put your metabolic rate up as much. So I'm a lost cause, unfortunately. Address negative habits such as smoking, alcohol, and diet. Really important. A really important question in terms of alcohol is when you ask someone how much they drink, and they say, 1 or 2 glasses, and then you ask them how many do you have on a good day, and they say 8. You actually have to ask the question. Same with cigarettes. So how many do you have a day? 4 or 5. If you go out to the pub, how many do you have a night? Another 6, 7, 8, 9, 10. A packet. So you've actually got to ask those questions because use of non-prescribed medications is an issue, as is prescribed medications. And you do need to review their medications, particularly with analgesia, understanding that if they're already on analgesics, they may need more analgesia when they're in hospital after the surgery because they've had an acute on longer term problem. One of the big issues in terms of acute hospitals is they assume because you're on analgesia before the operation, you're going to be fine with the operation. It's never the case because you've got a new insult. So you have to treat the new insult. So the most studied area, and we'll finish up fairly quickly, physiotherapy. We've already had a lot of discussions with this in the meeting so far, but the critical thing is you start with mild to moderate intensity activities, build up very slowly. Start low, build up slow. Resisted activities are pretty well okay for the non-affected limb. You can use very mild resisted activities for the affected limb. In the past, we said that shouldn't be done. If you've got some activity in the muscle, you can use some very mild activity, but you don't want to fatigue the muscle. So you've got to watch how you do that. So the rules are, you assess the physical capabilities, you tailor the exercise to the person, you try and minimise pain and fatigue, you monitor for new weakness or pain, and you progress slowly with respect to intensity. Last thing, nutrition. One of the great things I heard yesterday, because I'm a bit of a carnivore, unfortunately one of my failures is my daughter's a vegan, is the need for protein. And one of the things that the dietitian said, which was really important, is there's probably an increased need for protein within the polio population because of the risk of muscle atrophy and wasting. So something to think about. So you want to minimise your loss of mean body mass by using protein and supplements. One of the good things if you are monitoring things is to use a food diary, like an exercise diary or a pain diary. That can give you an idea of how a person's performing. And certainly a dietitian is of value, particularly in all of us above the age of 50. I would suspect that a lot of us have had more cakes than we need to over the last couple of days. And that has supplemented what we really should be eating. But really, really important. And the idea of treating your nutrition state before the surgery is because you have a catabolic state, so a destruction of tissues with your surgery. So you want to minimise the loss there. And finally, just as a summary, so we know that if there's a role for intervention to improve quality of life and function, it should be considered, but we need to take into consideration the ramifications that has for the polio survivor. Thank you.